To our After the Grand Rounds post show. It's an opportunity to have a little more conversational interaction on some of the topics we discussed today, give our speakers a chance to make any final points they want to make, and cover the questions that we weren't able to cover during the regular Grand Rounds period. I will be your host from my kitchen, along with two of our chief medical residents. And so we'll just go ahead and get started. And I think, this question could be for any of you. I think it was directed by our audience to Dr. Beckham. And the idea is about the number of postmortem evaluations of COVID patients. A lot of hospitals actually are not doing this as policy, as we didn't know how COVID would be spread. Can you talk about what we're doing in our system and what our access is to good tissue samples to help get some of this work done?
Yeah, I think it's a great question. And we haven't really established, we work with a neuropathologist very closely in the hospital. And I think everyone, honestly, whether it's here or other sites, have just been trying to keep up with the clinical care and just focus on that. And I think people, haven't established some of these postmortem analysis that we usually do in a kind of a normal period of time. For example, we have an ongoing collaboration with BK DeMasters, one of our neuropathologists, where when she gets an encephalitis case, she'll often contact us, and we kind of work with them during the autopsy to obtain samples and to do analysis and things like that. And so I with the restrictions in terms of who's allowed in the hospital and some of the other things like that, it's been difficult to set those things up. So I think it's more of just a functional problem of people not being able to pull all this together yet. And like you said, I think early on, we actually didn't know what the risks were. And, but I think now that we kind of have a little bit better understanding of the virus and some of these associated risks, we could set up a program where you could actually prospectively do this and answer some really important questions. I don't know if the others have insight as well.
No, I guess I would just say that, if you look at the more generic systemic autopsy studies that have been published to date, often a little bit, not surprisingly, perhaps the nervous system is sort of an afterthought. So sometimes they'll, use it as a tissue that they'll measure, say, viral levels in, but not describe the pathology, or they'll just describe the pathology in a sentence or two. So, it's not like there's a huge base of understanding out there from, outside this institution.
Great. I have a quick question as well. Sorry, I think we've got a little bit of an echo in here. I don't know if this is something that you guys are actually seeing, but how do you feel like the clinical manifestations are correlating with the imaging studies? There seems to be maybe a little bit of a disconnect in terms where lesions are seen on neurologic imaging as well as the signs and symptoms reported. Is that actually something that's happening, and is there any sort of correlation to this?
Yeah, I think one of the really interesting things is, now they're starting to be more in the radiology literature, this more and more extensive description of the MRI findings in COVID. And, I talked a little bit about that in terms of, people are reporting these funny leukoencephalopathies or white matter abnormalities, maybe microhemorrhages, maybe some, if they're doing MRI with some of the perfusion sequences and some of the encephalopathic patients, they describe frontal hypoperfusion, but often the correlation between those lesions and what you see clinically hasn't been great. But in some cases, it's not clear what the correlation would be. So if you have scattered white matter lesions or something, maybe all you would see is hyperreflexia, or maybe the frontal hypoperfusion is actually a good correlate with agitation or just a disturbed mental status. But so far, you're right, and I can't tell whether that's the bad neurology, and I don't mean that as a criticism. I just mean it as, these are really sick patients with a lot going on. It's really hard to do a good neurologic exam even under, optimal circumstances, then throw in all the COVID precautions and everything. But, often the description of the patients, isn't great. So I agree with you. I think sometimes you're a little surprised at either the presence or the absence, either way, of MRI abnormalities.
Interesting. Thank you.
All right, so I have a question for Dr. Jolly. First of all, thank you so much. That was a wonderful talk. And one of the questions that came up for us is, there are all these positive interventions that we can do in the ICU, but a lot of them take a little bit of traction, a little bit of time to really be implemented. And I think one thing we've all seen in practice is the ABCDEF bundles, which are sometimes lagging behind. So how do you think that we can improve this uptake in the implementation of these bundles into our ICUs, in particular our COVID positive ICUs?
Yeah, so I think it's challenging in the ICU and even more challenging in the COVID ICU. I do think there are ongoing quality improvement projects that are looking at trying to optimize the ABCDEF, in part leveraging EPIC and the EHR to kind of make it more protocolized and formalized for us. I know Arun is doing that in the intensive care unit. And so I think it really needs to come from a leadership level at the ICU leadership level to make sure that these protocols are happening on a daily basis and that they're integrated in the easiest way for everybody, because many of them are multidiscipline and require a lot of collaboration. And so making sure that that's done in a way that doesn't impact workflow and gets it implemented as quickly and easily as possible. But I think in the COVID ICUs, there's these extra layers of challenge because of the infectious risk of the patients, and that we just can't do the same things that we would do as part of the ABCDEF bundle. So I think trying to get patients up and moving in their rooms as much as possible, trying to engage families through technologies using either the iPads at the bedside or phone calls or some way to keep them engaged with their loved ones, and then focusing on critical care best practices. I mean, we can still do SBTs, we can still try to minimize sedatives as much as possible. So there are some things we can do in the COVID ICU and then some things that are more challenging.
Sarah, is there good evidence that if you do these kind of interventions that you decrease, say, time on ventilator or improve ease of weaning? Because, again, if we're going to see a second wave of this, one of the really sort of almost selfish, other than good medical care reasons, for doing this is if you have a limited supply of critical ICU resources and you can use them better by doing these things on these patients, God forbid we do get a second wave and it starts to strain capacity. Doing this may not just be good care, but actually, critical to improving overall access to resources and survival.
Absolutely, yeah. And the ABCDEF bundle has been shown to reduce ventilator times, to get people out of the ICU quicker, so to limit resource utilization. I think there's a little bit of concern about early weaning in the setting of COVID, that you don't want to extubate too early, because then if you need to re-intubate that patient, then there's the infectious risk of re-intubation. But I think in general, the push has been towards trying to adhere to the ABCDEF bundle as much as possible, even in our COVID patients.
And Sarah, on a regular sunny day, what is the best way to get these bundles, traction within the ICU? Because I think there's all the differences in COVID, but then there's all just the regular problems that existed before and after COVID.
I think that it really has to come from physician leadership and kind of multidisciplinary leadership, that it needs to become part of standard practice, right? The protocols just have to become second nature and kind of take them out of the hand of docs and put them in a way that they get implemented at the unit level, either by the RTs, by the nurses, by the physicians, or a group of those all together, to make sure that it's happening on a day-to-day basis. And then I think auditing to make sure that it's happening over time and that it doesn't drop off when a new provider comes on service and a new team comes on service. There has to be some way to maintain longevity there.
I have a question, could be for any of our panelists here. We've got this novel viral agent that we don't quite know what it does, and we've been throwing at that thing novel treatment agents. So we've made a nice, interesting cross for ourselves. Do we know anything about the effects of remdesivir, sarilumab, hydroxychloroquine on the CNS, on the effects for myopathy, any of these things, and how that's complicating our picture?
I guess I'll take an initial stab at that. I mean, I think we do have some initial data that's come out on some of these in terms of efficacy and safety. Remdesivir, I think the safety data is pretty clear. It's a safe drug. The nice thing about remdesivir, it's a prodrug So it's kind of like acyclovir in that it's a relatively safe drug with few side effects, and then it's activated, by the virus. There's some initial efficacy data that does suggest that it is efficacious and that it could potentially decrease length of or at least duration of symptoms and some of the other outcomes. And I would say it's probably one of the more promising drugs that we have. In terms of the other drugs, from the IL-6 inhibitors to the to hydroxychloroquine, I think a lot of the data is still yet to be determined. I think there's been a lot of noise lately about the hydroxychloroquine studies, especially there was a Lancet, paper that just came out that was kind of a large database, a retrospective database kind of study. And, there was some suggestion that there's a worse outcome in those patients that were receiving hydroxychloroquine. Again, any kind of retrospective database search has problems with controls, and there's several different prospective randomized blinded controlled trials going on right now. For example, the ORCHID trial, which I think is going to give us really good data on efficacy. In terms of safety, we know hydroxychloroquine has a number of different, effects. The big one that people are worried about, obviously, are the cardiac effects, especially in patients with underlying cardiac disease. And there's, I think, definite concern that could be, contributing to worse outcomes, at least based on the retrospective data. But we definitely need the prospective randomized data in order to know. And it's not too clear, to me at least, that any of these have a specific, are causing a specific complication in terms of making a diagnosis for a CNS specific outcome. But again, we just don't have the data yet. I don't know, at least in some of the trials and some of the discussions that I've had with people running these trials, whether it's Tom or Adit or some of these others, there hasn't been a big safety signal yet in terms of, that we shouldn't be using any of these. But I think, again, we use them in the context of a trial, we get the data, and then we'll be able to understand more.
The only thing I might add is, with the exception of remdesivir, if you think about it, the IL-6 inhibitors, the idea of using convalescent plasma, hydroxychloroquine are all drugs that or approaches we've repurposed. So we also have the benefit of understanding what their complications were, in settings in which they're in widespread use. I think the interesting thing, as Dave says, is going to be, are we going to understand, do some of these have benefits as it specifically relates to some of these neurologic complications, as opposed to just overall, benefits on the disease? Do those always track in parallel? Meaning, if I tell you if it's good for the disease, it's good for the nervous system, or are there going to be some examples where we would have said, oh, this is a better approach for patients with the neurologic part of this? But the only way you're going to learn that is the way, Dave suggested.
And I think, in terms of the convalescent plasma, since I guess I'm running the trial, I guess I could give you some of the interim data in terms of at least safety. We know for convalescent plasma, we've enrolled about 100 patients, and we've had about 5 AEs that were related to the transfusion. All 5 of them were minor AEs related to febrile kind of reactions that were pretty easily treated. And then in the large Mayo data set, which is currently in preprint, I think they had 5,000 transfusions of convalescent plasma in their data set looking at safety. And I think their overall AE percentage was around 0.8, 0.6 to 0.8. So again, seems safe in this cohort of patients. I think the big question, obviously for convalescent plasma and a lot of these, is we need to do the studies in all the different populations, both here in Denver, but also in New York, and all these different populations. I think it's important to pick up, because obviously each geographic area has different patient populations and so I think it's important for us to get efficacy data in these different populations. So we'll hopefully have some of that data will start coming out, at least for our study, and I know for some of the others over the summer. And God forbid we have a second peak in the fall or something, and hopefully we'll have some more clinical data to work off of with if there's another round.
The only thing I might add is, to the extent that convalescent plasma represents a form of passive immunotherapy, what we've learned in both experimental models and in clinical experience is passive transfer of antiviral antibody tends to work better when it's done sooner as opposed to later in an infection. And one of the things I have to admit that's kind of interesting to me is the initial published uncontrolled studies that appeared. Often we're treating these patients, multiple weeks after the onset of their symptoms, and trying to correlate that with benefit. And I think that's going to be one of the conundrums in terms of the neurologic stuff is, can you get it to patients soon enough to see a signal? Because I'm worried, and this is what happened in trials of hyperimmune globulin for West Nile virus, that they weren't shown to be effective compared to saline or to non-immune gamma globulin. But if you really looked at the time windows, often they were given over a very wide time window, and it was hard to know if you had just looked at a bigger population where you gave this acutely, would you see a benefit?
Mm-hmm. Makes sense. Thank you both.
This is a little bit of a tangent. My husband is actually one of the child neurology residents over at Children's. He's a 4th year. So I keep hearing about possible neurologic complications from COVID in kids. Do you guys see this, or is there any sort of discrepancy between what we're seeing in kids and adults? And do you think there's anything that we can take away from that?
I think the most unique thing that seems to be occurring in the pediatric population, but is fortunately still rare as a numerical thing, is this fascinating, pediatric multisystem inflammatory disorder that, they originally called Kawasaki-like. And of course, that's kind of like naming something after an enigma a little bit, because I'm not sure that we're brilliant about understanding what causes Kawasaki as opposed to maybe its manifestations. But I think that is a funny thing that we are seeing in kids, and maybe even in an older spectrum, of kids than we would have seen classic Kawasaki. And again, most of the speculation has been that that's occurring at a time that it does seem to make sense that this could be a post-infectious, immune reaction to the disease. So I think that's one that's a little bit unique. And there have been isolated examples of virtually everything else in the pediatric population. But I think overall, if you look at them, I think it is generally holding true that even though kids are as likely to be infected, they're much less likely than older adults to show symptomatic infection. And I think that would include the neurologic stuff. But there are rare single, cases of virtually, everything that we've described. So I think that's the current take. And maybe that's why there was so much attention to this, pediatric multi-inflammatory syndrome, because we were kept on saying, oh, one of the few blessings in this whole, a mess is that kids seem miraculously to be spared, in terms of serious illness leading to death or hospitalization. And then all of a sudden, this appeared. So, but again, the numbers are small, meaning in the hundreds out of, what would be a much larger infected population. So it's still a rare event, but it is disturbing and clearly increased in frequency. I'm not sure about others. The pediatric residents occasionally are emailing me about their cool cases. And no, I haven't, beyond that, I'm not sure I've heard of anything else unique.
Ken, did this come up late, this pediatric inflammatory syndrome, or did it hit the popular media late? Because it seemed like nothing happened to kids, and then all of a sudden there was this thing that was happening to kids all over the place. Was that a CNN effect? Was that just the literature catching up to the disease? What was that?
Well, I think, interestingly, some of the first reports were almost pre-literature, meaning, I think I may not have the chronology right, but the first ones were coming out of places like London and then very quickly got followed up in New York. So it was almost like a little bit of those were the sentinel events that then made people describe it and then, made more people aware of it. I guess it if you agree that it's a post-infectious event, the fact that it might be a little bit later frame shifted, meaning weeks after the acute event, might be a factor. But, again, this has been around since the beginning of the year, so you would have thought we would have seen more of it. So I'm not sure I know the right answer, except to say it wasn't so much the literature, because I think the warnings about this actually appeared almost before you could find a peer-reviewed case of it. And the first series are just, beginning to emerge in places like Lancet and elsewhere. So, I think it was doctors seeing something and calling attention to it. And then all of a sudden we're seeing that too, kind of phenomena, would have been my take. I don't know if Dave or Sarah, knows something I don't.
I mean, I think some of these post-infectious manifestations, there's also a component of, certain etiology or certain causes of these things being more common, for example, in Northern European populations and things like that. And I think what maybe helped what hurt in this situation was that, you didn't actually have any of these reports coming out of Wuhan or some of these other areas in Asia. And so, I think people were focused on what we'd already seen in China and some of these other areas. And I think weren't necessarily looking for these kind of events in some of these Northern European populations with things that might be more common in some of those backgrounds.
And Sarah, did you see that in your work as well? I mean, because were there things that were reported here that we sort of thought, or maybe some people thought, that what happened in Wuhan was just going to spread to here in its same form? Were there differences in ICU delirium outcomes, things like that we saw from, say, Northern Italy, Wuhan, et cetera?
So I think it looks pretty similar. There's not as much data on ICU specific delirium from Wuhan. There's just the Mao article that kind of described neurologic complications, and that was present in up to 30%, and some of that was likely delirium. But in Lombardy, in France, in Indiana, so far they've reported these incidences of delirium in the low 30s to up to the 70s in critically ill patients. So it's been pretty consistent across the board, despite where people have been. Now, whether that's a manifestation of critical illness or COVID specific is still not entirely known.
The one thing I might add is, most of our data, like the Wuhan data, is either single hospital data or single city data. And, what's happening a lot now in Europe, and I think they're probably a little bit ahead of us, having just, been engaged in the European Academy of Neurology's annual virtual meeting, is that they've created a whole bunch of both country-specific and even wider registries. So, I think that may give us all of a sudden a bigger N to say, how frequent are these things? And I wouldn't be surprised, hearing Sarah's talk and things, if a little bit we see more and more recognition of this neuropsychiatric stuff. I think it's, almost you can predict how these things are going to go. These patients come in, they're so sick, everybody thinks it's a pulmonary disease and focuses in on their, respiratory status and taking care of that. And they're intubated and you can't interact with them and they're sedated. And then all of a sudden you start to see the more overt neurologic things like, oh my God, he's not moving his right side, or, somebody gets an MRI and sees, a hemorrhage or stroke or something like that. And I think he's a little more, or she's a little more agitated, or the delirium, those things actually, almost predictively become the next wave. You understand that there's neurologic involvement, you understand the focal ones, where there's tissue injury. And then all of a sudden this group now, as you have a little more time, starts to emerge. So some of it, I think, is a bias of ascertainment. Everybody was so focused on, fix their SaO2 and keep them alive that you didn't even worry about the neurology at all, hardly. And then all of a sudden you start to recognize that. And then I think this will, be the next phase, to be honest with you.
I agree.
Yeah, so kind of along with that, with this increased risk of delirium and how we may not be thinking about it when these really critically ill COVID patients come in, is there any emerging data for anything that we could maybe add to the traditional ABCDEF bundles? And should we consider doing this preemptively in our COVID ICU patients and making kind of our new bundle for this population?
I think that the elements of the original one are good if we can just continue to implement them in some way. So I think we probably have to think about them in different ways, like how we're going to engage families, how we're going to move people. Can we move them in bed? Can we move them around their room? Um, so I still think sticking with the original ABCDEF bundle, but tweaking it to fit for COVID, if that makes sense.
Sarah, I don't know if it's how widespread it is here, but I know in some other places they, rather than necessarily have the acute care team dealing with all of this, they've almost created, practically a separate ICU service that really focuses in on this, because a little bit, of course, they're thinking that, the acute care team is so focused on the what's the ventilator setting or how's the blood pressure or the next crisis that sometimes this just gets left by the wayside. And if you create almost a separate, kind of service whose whole sole function is not to deal with the acute care, it's more to deal with this. Is that something you've seen or done, or has any validity to it?
Yeah, so that's certainly something that's been done in other places where they do ICU rehab rounds to kind of look at some of these elements to try to think about early rehabilitation within the ICU. And I know that there's interest from PM&R to do that, and they've opened up the acute rehab at UCH to kind of facilitate rehab for some of these patients. I think it's a really important point because a lot of these patients can't go to the typical subacute facilities or to long-term acute care facilities, so they're going to be with us in that post-ICU rehab period. So thinking about how we can optimize in-hospital rehabilitation, both in the ICU and the post-ICU period, I think is really important. And there are a lot of people thinking about it and trying to put things in place, but it's still a moving target.
Makes sense. Well, I think about what else we can do for the patients, maybe where we should end today, because that's always a good place to start and stop. So I will say thank you to Dr. Jolly, Dr. Tyler, Dr. Beckham. Really appreciate fantastic grand rounds, so interactive, several hundred people listening. So I know we all appreciate on the campus your efforts. Thank you all for what you do.
Thank you.
For the invite.
Thanks, everyone. Thanks for the invite.